is. I was surprised to see you here, Nigel, quite honestly. Ah.
Well, you will eventually, at least. I think the lights also make it hotter.
Mm-hmm. Oh yeah, I don't think I've ever been cold when I'm speaking. Get excited.
There's Sherry. Good morning. I guess you can hear us. Okay, that's rather simple.
My own purse.
Oh, yes, let's not do that.
I think people may still be drifting in, but in the interest of keeping us on schedule and having the time that we want for robust discussion, I will go ahead and open this session, Beyond the Western and Mediterranean Diets, Current Research Evidence and Priorities in Dietary Pattern Research. I'm Karen Collins. I'm a registered dietitian nutritionist, and it's been my great joy to serve as nutrition advisor to the American Institute for Cancer Research for 38 of its 40 years. I'm also a consultant working in a variety of capacities related to cancer risk and survivorship, cardiovascular nutrition, and its intersection with cancer. I will be opening the session with a look at some foundational pieces that will hopefully get our minds going and thinking about some of the larger concepts related to dietary patterns, and then we will have two speakers presenting their research. As I said today, I hope to lay a foundation and just get our minds opening wider or focusing more narrowly, whatever it needs to be, as a foundation for the discussions we'll have today. We'll look at the evidence about how we define and assess dietary patterns. We'll highlight some of the gaps in research and understanding, and we'll consider how we communicate about dietary patterns, whether that's within research studies and papers, whether it's in interviews with the media, or for healthcare providers in communication with our patients. So let's start by talking about how we evaluate the evidence. Right now, only the Western dietary pattern and Mediterranean dietary pattern have been reviewed as having evidence sufficient to warrant being included in the AICR-WCRF cup matrix, and both of those specifically related to risk of weight gain, overweight, and obesity. And since the Mediterranean diet has come up in some conversations here during the conference, I thought it would be a good place to start our discussion about dietary patterns, because some of the issues that we see about in this pattern are those that we will see across other dietary patterns as well. First, we have to recognize that there is no single Mediterranean diet. There never was, since different countries around the Mediterranean have slightly different twists and tweaks on it, and certainly as it's defined in research, there's also not a consistent definition. In the way it's scored in different studies, you might see olive oil as important, or maybe it's extra virgin olive oil that's crucial. Maybe it's not the olive oil, but it's the ratio of monounsaturated fat to saturated fat. We see grains mentioned in the Mediterranean diet, but it varies whether the emphasis is on whole grains or simply grains. And what about alcohol or wine? Is that a culinary or cultural component of the diet, or is it part of the health influence of the dietary pattern? Once we even agree on what the definition of a Mediterranean diet is, then there's a question of how we assess it. In some research studies, it's scored or assessed based on specific standards or criteria. But in many of the observational studies, it's actually scored either by above or below a median intake, or by quintiles or quartiles within that specific population. And since people across the world, and certainly in the US, vary widely in their consumption of olive oil, of vegetables, of fish, of meat in particular, that means that in any given pool of subjects, the same dietary choices could give you a high dietary score, suggesting a pattern quite consistent with a Mediterranean diet, or a low Mediterranean diet score, and just depending on who you're being compared to within the study. In terms of intervention studies, again, there are scoring metrics that are used to define it, but those scoring metrics used in different studies do vary. So whether you're choosing a metric for a study or whether you're talking about a study that has been done, it is rather important to know, for example, what was the role of dairy products in that Mediterranean diet score? How did they consider alcohol? And it's very important, especially for this dietary pattern, to know in what population the research was conducted, because again, in the same scoring system, a dietary pattern evaluated in a Mediterranean country will be more Mediterranean than that same sort of score outside of the Mediterranean area. And very important is to look at what the Mediterranean diet is being compared to. And this, again, is a consistent issue we'll see across dietary patterns. For example, if it's being compared to a low-fat dietary pattern, there are many ways to consume a low-fat diet, and they can vary considerably in the dietary quality. Now, one of the dietary patterns we'll be hearing about today is a low-carbohydrate diet. And especially for the healthcare providers, start right away by keeping in mind that when a patient says, I'm interested in a low-carbohydrate diet, or perhaps you may hear, I don't eat carbs, what they mean by what they don't eat and what you are envisioning may be quite different, because people do have interesting ways of defining what it is they're omitting. A true low-carbohydrate is defined as having less than 130 grams of carbohydrate per day, and in comparison with the current US adult average of 46% of calories from carbohydrate, it has less than 30% of calories from carbohydrate. A very low carbohydrate diet restricts that carbohydrate even further. And one of the things to keep in mind is that regardless of how low that carbohydrate is, when you reduce any macronutrient percentage-wise, automatically that means you are having a higher percentage of something else, either protein or fat or both. And as we look at that, those actual choices might be very important to consider. So for example, in the ERIC population cohort, looking at 25-year all-cause mortality data, you can see what a graph for total carbohydrate intake. But what you really find when you look is that when a low carbohydrate diet is achieved by replacing it with animal fat and protein, then all-cause mortality rates are higher. But when that carbohydrate is replaced with plant fat and protein, then all-cause mortality rates are lower. So it does matter what you substitute as you reduce your intake of any particular nutrient. And then when we talk about a ketogenic diet, a point often lost in the media and certainly with patients is that this is not just a low-carbohydrate diet. Yes, carbohydrate is brought extremely low, but a crucial point is that while protein doesn't need to be low, it cannot be a high-protein diet because the protein can go through the amino acids can go through gluconeogenesis, keep blood sugar too high. So it must be at least 70% of calories coming from fat. Now, another dietary pattern we'll be talking about today is a plant-based diet. And it is important to recognize that in the media, this is often used to refer to an all-plants diet. But in the scientific and health literature, we're often referring to a wide spectrum of dietary habits, which include predominantly plant foods and varying amounts of either limited or avoided animal foods. And in a review of dietary intervention trials using the term plant-based diet, Storrs found that of the 44 trials that met the inclusion criteria, less than 25% were actually vegan or plants only. And even when you look at the research, even within a true plants-only dietary pattern, there can still be variations about exactly what is included or excluded. Then there are variations of a vegetarian diet depending on which animal proteins are included or excluded, and a semi-vegetarian or flexitarian dietary pattern where, again, there's a lot of variation, and so you really have to look at what that meant, since there may be different, maybe only particular animal foods that are in or out, and the amount that's included as meeting that criteria can vary quite a bit. So one of the ways that this has been looked at, this concept of a balance between animal and plant foods, was called a plant-based dietary index, in which the researchers developed a scoring system where positive points were awarded for plant foods and reverse scoring for animal-based foods. But then, see, this doesn't really address the question of dietary quality, does it? Because there's a whole range of different plant foods. So the system was further revised and included, for example, a healthful plant-based dietary index. And then in this system, only plant foods regarded as healthy, like whole grains, vegetables, fruits, nuts, vegetable oils, were awarded the positive scores, and the less healthful plant foods, like sugar-sweetened beverages, sweets, refined grains, actually had the same reverse scoring that the animal-derived foods did. But even then, the devil's in the details. Some people would question, do all forms of potatoes really belong in the same category with sugar-sweetened beverages? And again, this is scored on the basis of quintiles. So the exact same dietary intake, depending on who else is in the study, might be considered high on a healthful plant-based dietary index or low. So you really do need to look at this. So let's talk a little bit about the gaps in the research. One that stands out to me is weight. We need to really, especially in a disease like cancer, where so many forms are related to weight gain, overweight, and obesity, it becomes a crucial question. Is a dietary pattern or healthful or at risk because of how it affects weight gain and obesity? Or is weight a confounder? Is the dietary pattern a mechanism by which to achieve a healthy weight or to avoid undesirable weight gain? Or is that a distraction muddying the water? And more, as we see that body mass index really does not reflect the full spectrum of body composition, what are the metrics we're going to use then if we're interested in what happens to visceral fat, if we're looking at lean muscle mass? Somehow we need to really take a look at whether it is as a confounder or a mechanism. How are we going to measure that essence? Finally, another gap I want to highlight is that we need to consider, both in our research and how we talk about it, whether we are saying a dietary pattern is the best way that we could see to achieve this objective or an equally good way to achieve the objective, because those really are quite different questions. when we have dietary patterns specifically targeting cancer-related pathways like inflammation or insulin resistance, if we see a change, is the change not just statistically significant, but actually clinically meaningful? And if there wasn't a change, one of the first questions to look at is, were these markers elevated to begin with? Because if you've got a population base where it's not necessarily elevated, it would not be surprising that the dietary pattern didn't change it. And also extremely important, and this is where my registered dietitian hat comes in, is that the effectiveness of a dietary pattern depends on continued adherence. As Justin Brown said yesterday in his presentation about exercise, where he was seeking to find the sweet spot, he called it, between maximal physiological effects with behavioral feasibility, I think it becomes very important for us to consider for each individual, is a dietary pattern going to work. In observational studies, we really need to consider what are the economic, ethnic, educational factors, as well as cultural fit, as well as cancer-related situation and comorbidities. What about health beliefs and values? How are all of these things feeding in to what makes a dietary pattern something that people are adhering to in the population you see, and what does that mean for other people that you might be talking to? When we look at intervention trials, we certainly see that those that have provided food improves adherence, which allows us to really address the question, what is possible if people really follow this dietary pattern? But it doesn't answer the question of what happens outside of a trial where people actually have to figure out how to do this on their own. In many intervention trials, we can maximize people's adherence with a significant education to begin with from registered dietitian nutritionists, showing people how to adopt this pattern, and ongoing support clearly makes a difference in many of these trials in ability to stay with it. But again, the question becomes then externally, if it takes a large amount of support for people to follow a dietary pattern, what does that mean outside of a study context for whether this is sustainable? And in several different studies, we've seen that the closer a dietary pattern is to someone's initial baseline dietary habits, the easier it is to achieve some tweaks, whereas if it's quite a distinct difference from their baseline, it is going to be much harder for them to achieve a dietary pattern that's highly adherent. So I hope that some of these things raise important things that you can find valuable, and I would propose this checklist of questions you might use, whether it's in setting up your own study or in communicating about it. First, again, what is the dietary pattern being compared to? And was that population based on specific standards, or was the comparison a high dietary pattern or low based on others in the study? We said in the opening plenary, we're hearing a lot about nutrition nuances, and yeah, that does make it tricky, but we have to be clear to people, yes, nutrition is nuanced. There's not a sweeping generalization, and so you do need to look at who was studied, was being compared, what were the confounding factors that either were controlled or might be influencing, and are we talking about short-term or long-term outcomes, and short-term or long-term dietary habits. And again, I return to me, one of the crucial questions, is this dietary pattern one way to achieve the outcome you're interested in, or truly the best way? How much heterogeneity was there in the study, and what does that imply for work going forward? And how much support was provided? How much support would be needed in order to continue this? So with that, I will close and introduce our first speaker, Dr. Shen, is speaking on insulin-lowering diets, keto, and low-carbohydrate dietary patterns. Dr. Shen is a medical oncologist and clinical investigator on the breast medicine service at Memorial Sloan Kettering Cancer Center. Her research focus is on targeting metabolic health to improve treatment efficacy and survival for patients with cancer. Dr. Shen?
Thank you for the introduction, Karen. Can everyone hear me okay? I just want to make sure the sound is good.
Yes.
Okay, fantastic. Well, thank you all for joining today. I regret that I couldn't be in person at this conference, but I'm in New York City, which is in the same time zone, so it's very bright and early here as well. And I've got my coffee, so almost feels like I'm there with you all. But thank you for being here this morning. I'm going to be speaking about insulin-lowering diets, and specifically ketogenic and low-carbohydrate dietary patterns and their potential utility in cancer care. So I'll start by reviewing why we might be interested in studying the keto and low-carb diets in cancer, how these diets affect weight and metabolic parameters. I'll review the current literature on what their impact is on cancer outcomes and illustrate how they can be used in very specific cancer settings, which is where some of my research is. And then I'll talk about some future directions for research. But overall, what I want to convey is that the utility of these diets for cancer endpoints has not yet been robustly demonstrated in a clinical setting. There may be some role in very specific situations, but overall, much more precision nutrition research is needed. So why are we interested in studying these diets, and how can they reduce tumor growth? Three main ways. The first of which is that these diets can potentially reduce systemic nutrient stores that are utilized by cancer cells. So you're likely familiar with the Warburg effect, which is where cancer cells have evolved to derive their energy from glycolysis rather than the more intensive and oxygen-dependent process of oxidative phosphorylation. And as part of that adaptation, cancer cells lose their ability to use ketone bodies as a source of energy. So by using a diet that places the body in a state of ketosis, we're essentially depriving cancer cells of their energy source, whereas normal cells can continue to metabolize ketone bodies. The second reason is that these diets can potentially alter insulin-related signaling factors. So when insulin binds the insulin receptor, it activates a pathway that ultimately results in cell proliferation and survival. And cancer cells can take advantage of this pathway through gene mutations and hyperactivation. So by reducing systemic insulin levels, potentially we can reduce tumor growth in that way. And the third reason is that these diets can improve weight and metabolic parameters. So I'll give an example in breast cancer, which is my area of specialty. We know that many women with breast cancer following diagnosis gain weight as a result of the treatments that we administer, like chemotherapy and endocrine therapy. And that weight gain above a specific threshold is associated with worse cancer-specific and overall survival. Similarly with insulin, the treatments that we give can worsen insulin parameters, and these are also associated with worse outcomes. So perhaps by targeting these parameters, we can improve cancer outcomes. So let's look at how these diets do affect weight and metabolic parameters. And we'll start with weight. These data are from a study of 20 healthy adults, did not have cancer. They were admitted to an inpatient service and given all of their meals over 2 weeks. And participants were given either a low-fat diet, which is abbreviated LF and shown in blue, or a low-carb diet, which is abbreviated LC and shown in red. And over the course of 2 weeks, you can see that patients on either diet lost weight, and by the end of the 2 weeks, a similar amount of weight on the order of about 2 kilograms or 5 pounds or so. But one of the concerns with the low-carb diet in particular is where that weight is coming from. So if we look at the middle graph, fat-free mass, the low-carb diet resulted in a significant loss there of fat-free mass as compared to the low-fat diet. But in terms of fat mass, there was actually less loss of fat mass with the low-carb diet. What about in cancer-specific populations? So these data on the bottom here are from the Keto Comp study, which was in breast cancer patients in about 60 women who were undergoing radiation therapy. So they had body composition measures throughout the study. And so looking at each of these box plots, you'll see that women who are randomized to the control versus keto arms, and there's 2 boxes in each arm which we can ignore for the purposes of this talk. That was looking at 2 different types of radiation that they were given. But you can see that overall body weight, which is shown in yellow, again, did decrease over the course of a couple weeks during radiation treatment with the keto diet. But at least in this study, reassuringly, that change was mostly from fat mass, which is shown in orange, and fat-free mass and skeletal muscle mass, which are shown in blue and green respectively. There was a relatively small reduction from the keto diet. So at least we can be reassured that there's not too much skeletal muscle mass in this population. So looking at metabolic parameters, the table on the left is a summary from various studies of what these diets do to metabolic parameters. We would, of course, expect, just based on how these diets work, that hemoglobin, A1C, glucose, and insulin all decrease. But the impact on lipid profiles is quite mixed. And in particular, LDL, the bad cholesterol, seems to increase, particularly on the keto diet. And that makes sense because we're substituting carbohydrates with fat. So this graph on the right is, again, another study in healthy adults who were admitted inpatient and given their diet. So the low-carb, high-fat diet shown in red, you can see LDL levels increase over the course of the study, whereas with the control diet, they really remain stable or even slightly decrease. HDL levels, the good cholesterol, also decreases, unfortunately, but there is a beneficial effect on triglycerides. And so overall, with total cholesterol, it ends up being kind of a net neutral effect, where the total cholesterol level remains the same. But this is a concern with these diets and implementation long term because, you know, at least in breast cancer, among survivors, the leading cause of death is cardiovascular disease. It's not cancer recurrence. And so thinking about an increased LDL over time, which increases risk of heart attacks and stroke, that's definitely a significant concern with these types of diets. And the effect on C-reactive protein, which is an inflammatory marker, has really been pretty neutral. So let's look at the data on what the impact of these diets is on cancer outcomes. So Karen alluded to this study a little bit. So in the prevention setting, it's of course very difficult to study these diets because you need a huge population and long-term follow-up. But we can look at these large cohort studies. So the ARC and PURE studies included over 15,000 adults who were given dietary questionnaires and were followed over decades for outcomes. And what they found, interestingly, is that there's this U-shaped curve between energy, the proportion of energy derived from carbohydrates and risk of mortality, with the kind of sweet spot or the bottom portion of that U-shaped curve really in the 50 to 60% range. And that either end of the spectrum, including very low, like our keto diets, is associated with increased mortality. So that's a concerning finding. And I think we'd be remiss to be at this conference and not mention the AICR cancer prevention recommendations. And specifically the keto and low carb diets, I think make it difficult, not impossible, but difficult at least, to adhere to at least 3 of the kind of central tenets of the AICR recommendations, which are to limit consumption of red and processed meats, to limit consumption of processed foods that are high in fat, and to eat a diet rich in whole grains, vegetables, fruits, and beans. So by severely limiting that amount of carbohydrate in the diet, it's hard to get that protein and fat in from vegetables, and oftentimes requires some consumption of red meats and other processed foods, which is against cancer prevention recommendations. So looking at the early stage cancer setting, this is a meta-analysis that was published last year that found only 4 studies that were of high enough quality to be included, that looked at, that randomized patients to either a keto or a low carb diet and a standard diet. And I want to highlight a couple things. The first is that these sample sizes are generally low, so on the order of 30 to 80 patients or so. And the duration of these studies, the intervention, is quite short, a couple weeks, at maximum 24 weeks, which is 6 months. And the adherence rate ranges between 50 to 75% on the intervention arms. I'm going to point out 2 of these 4 studies specifically that did include some cancer endpoints. So this study was in breast cancer patients who are undergoing chemotherapy, and they included breast cancer patients of all stages, about 80 patients, and randomized them to a keto or a standard diet for 12 weeks. And they found that women in the keto diet arm did lose more weight. They had improvements in the kind of expected metabolic parameters like insulin and hemoglobin A1C. Quality of life improved as well, which was great to see. And the cancer endpoints that they looked at included tumor markers, which numerically decreased slightly, but was not statistically significant as compared to the standard diet arm. And in this study, they reported that those on the keto arm had a greater reduction in tumor size on the order of almost 3 centimeters as compared to about 0.6 centimeters. But in this study, the way that tumor size was assessed was based on ultrasound pre and post intervention, which is highly subject to technique and the technician, or they used pathology reports and compared pre-treatment imaging to post-treatment pathology reports, which are oftentimes, it's difficult to compare between these two different modalities. So overall, this trial did not use standard clinical trial response criteria, which are RECIST criteria. So we have to take these results with a grain of salt. This next study was in prostate cancer patients who were initiating androgen deprivation therapy, and they were randomized to a low-carbohydrate diet or a standard diet for 6 months. And they also similarly found more weight reduction in the low-carb diet arm, particularly with total body fat reduction. And they also found improved serum metabolic parameters, again, particularly insulin levels at the 3-month mark. They looked at prostate-specific antigen, which is the tumor marker in prostate cancer, and found no significant difference between the arms. I will say that this study was originally designed to include 100 patients for the primary endpoint, which was an insulin endpoint, not the prostate-specific antigen endpoint. But they ended the study early due to slow accrual. So perhaps had they been able to reach their full accrual, we may have seen more of a difference in the tumor marker, but as such, there was no significant difference. So overall, in early stage disease, it seems that implementation of these diets is certainly feasible. There's improved quality of life. It may improve weight and some metabolic measures. But overall, from this meta-analysis, these diets are really inconclusive as anti-tumor therapies. There's no significant reductions in tumor markers, and certainly not in cancer-specific endpoints, like, for example, recurrence-free survival. And there's no randomized controlled trials that have been powered to cancer-specific outcomes that have been reported. So looking at metastatic disease, these are the prospective clinical trials that have been done in this setting. And there, you can see that there's just 3, and they're single-arm safety and feasibility studies with very few patients, fewer than 20 per study. In this first study, all 3 of these studies were looking at any site of cancer, at least as long as it was advanced stage. This first study found that implementation of a keto diet did decrease weight, and there were improved quality of life parameters. And while they reported that greater weight reduction was associated with the likelihood of having achieved stable disease or partial response as opposed to progressive disease, there was no significant correlation between that clinical outcome and the degree of ketosis or glycemia that was achieved with these diets. This study of 12 patients also showed decreased weight with the keto diet. There was no unsafe adverse events. They actually did report that the extent of ketosis seemed to correlate with having achieved stable disease or partial response as compared to progressive disease. But again, 12 patients, very, very small population. And then finally, this third study of 16 patients had patients be on a keto diet for 3 months was the goal. And unfortunately, out of the 16 patients, only 5 patients were able to complete that intervention. Most of the patients in this study had a very difficult time adhering to the diet. There were issues with tolerability. Some patients had progression of disease and needed to go back on chemotherapy. And they reported that quality of life measures actually worsened over the course of their study. So overall, in the metastatic setting, while these diets do seem to be generally feasible and safe, they may improve some quality of life measures. This is shown graphically on the right from that first study where all of the symptom scores did seem to decrease. But I mentioned that third study where the quality of life measures actually worsened. So it's kind of mixed there. They may improve some metabolic measures, but again, no randomized controlled trials that have been powered to cancer-specific outcomes. So if this is the case, how can we use these diets in specific cancer settings? So I mentioned the insulin signaling pathway earlier. When insulin binds the insulin receptor, there's a downstream cascade of events that leads to cell proliferation and survival. So PI3 kinase is an enzyme in this pathway that's involved in signaling. And the PIK3CA gene encodes one of the subunits of PI3 kinase. And so mutations in the PIK3CA gene can lead to hyperactivation of this pathway in an insulin-dependent manner, and which can result in uncontrolled proliferation and survival. And PIK3CA mutations are among the most common across all human cancers, particularly common in endometrial and breast cancers. And numerous PI3 kinase inhibitors have been approved. The issue with PI3 kinase inhibitors is that one major adverse effect is hyperglycemia. And this happens because while there should be blockade of insulin signaling in the tumor, there is also on-target but off-tissue blockade of signaling in the liver. So there's a perceived insulin deficit by the liver, and so that results in secretion of glucose into the bloodstream and engaging in gluconeogenesis, and skeletal muscle has decreased uptake of glucose as well. And so hyperglycemia then is a major side effect. Clinical trials generally report hyperglycemia on the order of about 40 to 50% of patients, which is already a very high proportion. But we looked back at our data at Memorial Sloan Kettering at all breast cancer patients who have ever received a PI3 kinase inhibitor. And we found that while, yes, patients who were treated as part of a clinical trial setting, which is highly monitored, the rate was around 30 to 50%. In our standard of care patients, the rate of hyperglycemia was upwards of 80% of patients, and about 40% of them were developing grades 3 to 4 hyperglycemia, which is severe enough to warrant a dose reduction or a temporary or even permanent discontinuation of these medications. So due to this side effect, patients are really unable to derive the maximum benefit of these medications. So even if it's working in treating their tumors, the side effect is preventing them from staying on a full dose or for as long as it had been intended for them to be on these medications. So these are data from Dr. Cantley's lab, some of which he showed in his plenary session yesterday. So interestingly, PI3 kinase inhibitors not only induce high blood sugar, but as a result, the pancreas secretes a compensatory amount of insulin to bring the blood sugar levels down. So insulin levels spike as well after administration of PI3 kinase inhibitors. And that can be mitigated by preemptively administering a keto diet. So you can see here that with a keto diet on board, there is no spike of the insulin levels and they remain quite low. And the concern with high insulin levels in the setting of a PI3 kinase inhibitor is that insulin binding the insulin receptor can actually reactivate that insulin signaling pathway, even though there's a PI3 kinase inhibitor on board that's meant to block the pathway. So in the top left, this is immunohistochemical staining with just the PI3 kinase inhibitor alone of downstream markers in the insulin pathway. So you can see that there's still quite a bit of activation, but giving a keto diet really results in this kind of synergistic effect where there's minimal downstream signaling with the PI3 kinase inhibitor, which is the intent. And this is quantified in the graph on the right. So looking at this in a clinical context, so these are data from a patient with type 1 diabetes and a continuous glucose monitor and insulin pump. So at baseline, her total insulin requirement in a given day was about 45 units of insulin. When she's given a PI3 kinase inhibitor as part of her treatment for breast cancer, the total insulin, so again, this is type 1 diabetes, so no endogenous insulin. She's completely dependent on the insulin pump. Her requirement was over 200 units of insulin per day. But with administration of a very low carb diet or keto diet, that total insulin requirement came down to about 100 units per day. So at Memorial Sloan Kettering, we have a clinical trial open. That addresses this issue that's based on these data that I showed. So this trial is for women with estrogen receptor positive metastatic breast cancer who are going to receive alpelisib, which is a PI3 kinase inhibitor, as standard of care. So these patients are randomized to either a keto diet, a low carb diet, or a now standard diabetes medication, canagliflozin, which is an SGLT2 inhibitor. And they're on that intervention for 12 weeks. And the primary endpoint is the rate of grade 3 to 4, so severe hyperglycemia. And we're looking at cancer-specific endpoints of overall response rate and progression-free survival as well. And so the hypothesis here is that any one of these interventions not only will reduce the high proportion of that adverse effect of hyperglycemia, but also by lowering insulin levels will allow a more maximal effect of the PI3 kinase inhibitor and prevent that reactivation of the insulin signaling pathway and thus translate into these improved cancer outcomes. So this trial is open here at MSK. We're also opening imminently at Cornell and Ohio State University. So what are some future directions for research then? I mentioned many of the challenges of these diets, which are tolerability and quality of life issues, problems with adherence, especially in a long-term setting, concerns about weight loss and skeletal muscle loss, particularly in cancer patients, and unclear long-term effects, particularly with that rise in LDL levels and thinking about cardiovascular health long-term. So what are future directions? You know, I think that clinical trials that include these types of diets need to include biomarker analysis. We really need to be identifying the patient population that can best benefit from these diets. So for example, patients with PIK3CA mutations or other mutations in the insulin signaling pathway like AKT, for example. Trials need to include safety parameters. So considering including only patients with high body mass index, or as we all know, that's not an optimal measure of metabolic health. So perhaps including specific body composition measures like high total body fat percentage, and excluding patients in whom there's a concern for cachexia or failure to thrive syndromes, and including safety stopping rules for significant weight loss or weight dropping below a specific threshold, for example. Trials need to include appropriate endpoints. It's certainly difficult with dietary interventions in general to demonstrate a real impact on longer-term cancer outcomes, but at least looking at metabolic outcomes that are correlated with survival in these populations. And we, of course, need sufficient power and sample sizes to demonstrate a difference with these diets. So in conclusion, I hope I've shown that keto and low-carb diets can result in decreased weight and improvements in insulin, although there's a mixed effect on lipid profiles. But overall, the impact on cancer outcomes really is unclear, and we can't broadly recommend these diets for use in a cancer setting. But perhaps we can consider these diets in specific settings that are being studied in an ongoing manner. But overall, again, we need more precision nutrition research. So with that, I'd like to thank the conference chairs and organizers for giving me the opportunity to speak today, and I'm looking forward to your questions and the discussion. Thank you.
Thank you, Dr. Shen. That was fantastic. And now we will open for questions. Yes, go ahead.
Hi, Dr. Shen. Thank you so much for that presentation. I'm Komodo from the IARC, International Agency on Research for Cancer, branch of the WHO. I had a couple questions. I'll start with the two really quick, fast ones. I was wondering if you went over how those studies ensured that the participants were in a state of ketosis, or if that was even a concern. Because essentially they're just following a low carb diet. So if even being in a state of ketosis was a consideration. And also, I think you mentioned at some point a patient with diabetes, and I am aware that patients with diabetes are at an increased risk of going into ketoacidosis.
Yeah.
So I'm wondering if you have been exposed to that.
Yes, great questions. Most of the studies looking at keto diets did include serum measurements of ketones, and some of them included that as a measure of adherence and reporting the percentage of patients that were adherent. I think serum ketone measurements is a little bit difficult because patients have different baseline levels of ketones and different increases with the degree of the diet they are adhering to. And so it's a little bit difficult to just draw a line and say that patients are adherent or not just based on the ketone level necessarily. But yes, most of the studies did include that. And that one study I mentioned looked at ketone levels and correlation with stable disease or partial response as compared to progressive disease. That was that very small metastatic study of 12 patients. So that's at least an interesting finding there. To speak to your other question of patients with diabetes, yes, safety is a huge concern for these patients. So in the trials that led to the FDA approvals of PI3 kinase inhibitors, they mostly excluded patients with diabetes. So the exclusion criteria was often a hemoglobin A1C of less than 8%. That was required. But for example, in breast cancer, the SOLAR-1 trial that led to FDA approval, they actually halfway through the study found that there was still such a high level of hyperglycemia that they even tightened that inclusion criteria further to only allow patients with a hemoglobin A1C of less than 6.5%. So safety is a huge concern in these patients, and I think we would have to be very careful in recommending these types of diets, which is really why we need more research. But similarly, in our trial, that's an exclusion criteria as well.
Yeah.
So have to be very cognizant of that. Thank you.
I have one last question, and this I'm really curious about. So when you talked about how LDL or bad cholesterol, you have found that that does increase on keto, while the good cholesterol, HDL, actually goes down. But it's bad. That's a bad thing. But I was wondering what the source was for replacing these fats, because as Karen pointed out, when we find that we replace the sources with animal-based proteins, we find an increase in all-cause mortality risk, whereas plant sources leads to a decrease. And I know that it's a lot more difficult to obtain a high-fat diet from plant sources, but if you are consuming, I'd say like 80% of your calories from roasted vegetables drowned in olive oil, this would be very different than eating bacon. And
absolutely. Butter. Yes, absolutely agree. And that hasn't really been demonstrated, looking at specifically exactly how to modify the diet, even within the parameters of a keto diet. And in the cancer setting, most of these trials, I should say all of these trials, were based on education and counseling of patients, but ultimately they go home and prepare their own diets. That's as opposed to some of these healthy subject studies where patients can be admitted and given their entire diet, and that's in a highly controlled setting, right? So when we're letting patients go home and eat their own diet, it's very hard to study these differences in saying, oh, you're adhering to a keto diet, but you're, mostly plant-based still versus, eating bacon, like you said, or processed foods and red meats at home. So it's really unclear how much difference there would be between those two types of keto diets and the effect on these other lipid parameters. So we don't know, but presumably there would be less of an effect on LDL and HDL.
Yeah, I think that would be a super interesting study. Thank you so much.
Hi, Sherry. Peter Cornelius and Everix. I apologize, I missed the beginning of your talk. Are you familiar with Walter Longo's work with the fasting mimicking diet?
Yes.
Did you talk about that at all? Because they published some striking data in cancer outcomes, albeit outside of an RCT.
Yes, yeah, there's been a lot of interest in fasting mimicking diets and time-restricted feeding as well. I think, the preclinical data has been very interesting, very striking. In a clinical setting, patients who adhere to fasting mimicking diets certainly can lose weight. And there's been a lot of interesting clinical studies too, specifically in like a chemotherapy setting, for example, helping patients to tolerate chemotherapy better. So again, these very specific settings, but not necessarily as an overall anti-cancer strategy. But I think certainly also worth further exploration. And it seems to be a little bit more tolerable to do that than a keto diet.
Hi, Sherry, it's Erica. This is a great presentation. Thank you so much. I just wanted to highlight that I think you maybe already alluded to this, but in the studies, the meta-analysis, the Yang study, did they explain the different types of keto diets they used in each study? Like, was there a difference between like the well-formulated ketogenic diet? Were some studies a low glycemic index diet, modified Atkins? There's so many different definitions of keto, and I think this presentation really highlights one of the biggest challenges we're facing in nutrition research right now, and finding consistency in just the diets themselves and the definition.
Absolutely. Thank you, Erica. I think this just really speaks to, as you mentioned, one of the major issues, which is there is a lot of heterogeneity in studying these types of diets. So even within the definition of a keto diet, exactly how many grams of carbohydrates varies between the studies. And oftentimes there was no mention in the studies of specific glycemic index foods and that sort of thing. And so it really does make it difficult to compare between these studies and draw conclusions. So I think that's a major issue here.
Any other questions? Then let's move on to our next presentation. I'd like to introduce Esther Farley, presenting on defining plant-based dietary patterns in cancer research. Ms. Farley is an oncology certified nurse working in Oklahoma and a PhD student in the School of Nursing at the University of Buffalo, interested in the intersection of diet, especially whole food plant-based diets, and gynecological cancers. Esther?
Thank you for the opportunity to present. So as I began my health career, I worked in a setting where many people were intentionally changing their lifestyle from an omnivorous sedentary pattern to a plant-based active one. Under medical doctor supervision, I watched as they rapidly improved in health, decreasing blood lipids, reversing insulin resistance, losing weight, and overall gaining a greater sense of health and well-being. It was a powerful experience to see personal health behavior change substantially affecting physical health and well-being. In recent years, as I'm working with oncology patients struggling with their health at many different ages of life, I continue to love observing the blue zone health experienced by my parents and their many friends who, more than a dozen years into their retirement, are reveling in an active life, hiking miles at high elevation in Colorado, volunteering on mission trips doing construction, and easily keeping up with their active grandchildren. In my doctoral studies as a nurse, I'm looking at the intersection of a healthy plant-based diet and cancer, especially female cancer. As we know, in the WCRF AICR Continuous Update Project reports from the last decade on various female cancer, there are only limited, inconclusive evidence of association between specific dietary components and female cancer at the time of those publications. The same holds true for any specific dietary pattern. In the literature review I presented in my poster presentation, I was looking for the association of plant-based diets and gynecological cancer. This is the cancer population I've been mostly working with inpatient for a number of years. Our local cancer center in Oklahoma City is the regional specialist, and many patients travel significant distances to see our physicians. As I searched the literature, I was disappointed to see that due to the lower prevalence of these cancers, they're often not able to be included in statistical analyses. So I'm currently working on a broader review of female cancer, including breast cancer, and plant-based dietary patterns, and expect to submit it for publication sometime this winter. As studies have become more careful in defining dietary patterns along the lines of healthy foods, not simply the presence or absence of animal foods, the risk reduction of female cancer has become more clear. I'm able to include studies published at least as far back as 1983 comparing the female cancer risk in relation to plant-based dietary patterns. Historically, the primary divisions were based on the presence or absence of animal products in the diet, and this may have been more relevant when the prevalence of highly processed foods was less. Studies were conducted with known populations of vegetarians in the UK, Germany, and the United States, including the forerunners of the EPIC Oxford cohort and the Adventist Health Study cohort. In order to broaden the study to the general population, a number of researchers utilized some form of principal component analysis, looking for dietary patterns and often comparing plant-based groupings with those consuming larger quantities of meat. This gave some information, but it still wasn't a clear delineation and didn't cover the entire dietary pattern, which is part of the criteria for my review. In 2014, Martinez Gonzalez and colleagues used an a priori defined pro-vegetarian food pattern to analyze mortality in a Mediterranean population. Those conducting the Nurses' Health Study added to the idea by creating a plant-based diet index, which Karen has already referred to, which is composed of 3 specific scores: an overall plant-based diet index, a healthy plant-based diet index, and an unhealthy plant-based diet index. Satija and colleagues published their first study using this method in 2016, and this was proliferated into many studies of diverse cohorts looking for a variety of outcomes. This plant-based diet index scores a participant's diet not only on the plant foods included in the diet, but also the quality of those plant foods, giving positive scores for more healthful plant food groups like whole grains, fruits, vegetables, nuts, and legumes, and reverse scores to unhealthy plant foods and animal products. The use of these plant-based diet indices has rapidly proliferated. In a separate rapid review of the literature, I found around 80 studies using these indices for associating diet with various diseases and physical conditions. In all of these different ways of analyzing diet, the term plant-based diet has appeared, and it's also begun appearing more and more in the media, on food labels, and in conversations. However, it's not always meant the same thing. Dr. Storrs recently published a literature review on a wide variety of current studies using the term plant-based diet and discussed the implications of inconsistent usage. He identified 44 intervention studies that investigated the effects of a plant-based diet. All these studies included either a definition or a short description of the term plant-based diet. However, the descriptions of the dietary interventions varied significantly in detail. In several cases, it was impossible to determine which foods were included and excluded in a particular plant-based dietary intervention. 5 studies used the term plant-based diet interchangeably with the term vegan diet, but 50% of the included studies completely proscribed animal products. More than a third of the studies included animal products as part of the plant-based diet. Approximately 20% of the retrieved studies allowed participants to consume meat and fish during the plant-based dietary intervention, and the plant-based diet contained dairy products in 34% of the included studies. Of course, increased consumption of plant foods was a feature of all plant-based dietary interventions in these studies, and about 30% of the studies included a whole food or unprocessed aspect and used the prefix whole food to describe the plant-based dietary intervention in greater detail. Researchers have varying ideas about the content of a plant-based diet. The concepts range from a traditional vegan diet, excluding all animal-derived products, to a semi-vegetarian diet or even an omnivorous diet. This can have important scientific and clinical implications. Clear definitions of a term or concept are necessary to allow for scientifically sound and reproducible effects. The absence of a clearly defined concept, in the worst case, may lead to diametrically opposed results in scientific studies. This can easily be translated into clinical practice, so let's look at an example. In 1998, Yamashita and colleagues compared 2 isoenergetic diets designed to lead to weight loss in 36 overweight and obese women in a 16-week parallel design trial. One arm of the study emphasized red meat, and the other arm emphasized soybeans as the major protein source. Participants with a preference for daily meat consumption were allocated to the first arm. The second arm included subjects with a preference for plant foods who habitually ate more chicken and fish than red meat. The nutrients calculated from planned menus revealed a cholesterol content of 54 milligrams per kilocalorie in the second group. and this serves as an indirect indicator that their diet contains substantial amounts of animal products because strict plant-based diets are usually much lower in cholesterol. The authors found that weight loss was equal in both diets and concluded in their abstract that weight loss occurred equally with meat-based and plant-based diet. 7 years later, Barnard and colleagues published the result of a randomized clinical trial which examined the effects of a low-fat plant-based diet on body weight and metabolism. 64 postmenopausal overweight women were randomly assigned to either a low-fat vegan diet or a control diet based on the National Cholesterol Education Program guidelines. Adoption of a low-fat vegan diet was associated with a mean weight loss of 5.8 kilograms in 14 weeks. Weight loss in the intervention group was significantly greater than the control group that regularly consumed meat and other products. The two studies revealed contradicting results, but were both published under the same umbrella term, plant-based diet. So we can see the dilemma. In one of the studies, the term plant-based diet was used interchangeably with a vegan diet, whereas in the other, the usage implied the regular consumption of fish and chicken. Although both diets were very different with regard to their food composition, the results were published under the same umbrella term. The lack of a clear definition of the term plant-based diet and its inconsistent usage may cause significant ambiguity among researchers and the public. The term plant-based diet may only be useful in the context of a clear definition and a thorough description of the applied dietary pattern. Otherwise, studies concluding plant-based diets are difficult to compare and hard to reproduce. So reproducibility of research is a fundamental tenet of good science and requires meticulous and complete reporting of intervention parameters, especially for nutrition interventions that vary from study to study in many methodological details. To facilitate comparison and reproducibility of plant-based dietary interventions, Dr. Storrs has called for a standardized plant-based intervention reporting checklist. This checklist has 9 items that primarily focus on the description of the dietary intervention: the presence and frequency of animal products, the use of whole foods or restriction on processed foods, caloric restriction, restriction of salty or fatty foods, macronutrient distribution targets, specific supplements the participants are asked to take, and the support or supervision of the participants in the dietary modification. For observational research, the defining of the plant-based diet has moved from a self-defined diet where researchers accepted self-definitions of diet restrictions to using food frequency questionnaires. Analysis has moved from generalized definitions of the presence or absence of particular dietary items to dietary indices that score healthy and unhealthy aspects of the entire diet, plant or animal. These indices have provided the ability to analyze healthy dietary patterns in populations with few vegetarians and provide significant results on the question of plant-based diets for female cancer. As we move into the future of dietary patterns, dietary phenotyping utilizing machine learning is intriguing. Ramya and colleagues used a clustering analysis to create phenotypes. I'm particularly excited about the promising machine learning techniques used by Burgermaster, a nutrition scientist, and Rodriguez to provide psychosocial behavioral phenotyping. In this secondary analysis of psychosocial and behavioral data from a community cohort, they optimized a multi-channel mixed membership model using Bayesian inference to identify psychosocial and behavioral phenotypes and used logistic regression to determine which phenotypes were associated with elevated weight status. Through these methods, they identified 20 psychosocial behavioral phenotypes. The phenotypes were conceptually consistent as well as discriminative. Most participants had only one active phenotype. 2 phenotypes were significantly positively associated with elevated weight status, and 4 phenotypes were significantly negatively associated. Each phenotype suggested different contextual considerations for intervention design. And it's intriguing to consider how this could be also applied to more wide dietary analysis. So, especially thinking of it as a nurse, what does this translate into what we tell the public, our patients, and our clients? Clarity in research is as to what is meant by a plant-based diet can help provide better guidance. As has been mentioned in relation to exercise, a step-by-step incremental change is more effective in long-term change for most people. But let's not just leave them part way to health. Plant-based dietary indices show the strongest association of decreased risk of disease with the lowest use of processed and animal foods. Each step that we can take toward that goal will improve our health and lower our disease risk. Thank you.
Thank you. Fascinating presentation. We can open the floor now for questions to Ms. Farley.
Or move to the panel.
I'll ask one. So, as a practitioner, I'm really curious what sort of term or phrase gets the most traction for you in a clinical setting when talking about these kinds of diets.
I'm sorry, Melissa, could I ask you to speak up further, please? We're not hearing you very well.
Is the mic? There we go.
Thank you.
So as a practitioner, I'm just sort of curious what sort of phrases or terms get the most traction for you in an appointment in front of a patient when you're talking about the kind of diet you want them to consume. Do you get the most traction when you talk about plant-based or plant-forward or something else, particularly along that incremental change? And where do you start and then where do you move with them to sort of take them along with you, since everyone defines that a little bit differently?
Usually I don't use a dietary pattern specifically term. I might refer to it in general, but what I'm recommending for them is to add more healthy foods to their diet in a step-by-step fashion, because a sudden change is not usually going to be effective. And again, if I name a particular pattern, there's all different concepts. So I try to give it specific, feet on the ground, amounts and what they should improve in areas of diet.
So you're defining and describing and characterizing more than just applying the term. Thanks.
Absolutely.
Hi, Chris Mano, University of Illinois Urbana-Champaign. I had a question about the indices that you kind of showed on the screen. At one point, it appeared that they had been developed by Willett and those at Harvard. I was wondering if you could, and maybe I missed this, but if you could speak a little bit about the algorithm for those particular indices. There was like a healthy plant-based index and an unhealthy plant-based index, and the extent to which animal products are incorporated in those indices.
The entire diet is incorporated in that, and I am not technically a specialist in this. I'm just observing and learning on it myself. But healthy foods that are known to be healthy plant foods through other studies are given positive scoring, and unhealthy plant foods and animal foods are given reverse scoring to create an index score. And there's an overall one, and then there's a healthy and an unhealthy to provide different effects. It's a little bit too extensive for me to try to explain here and now, but I highly recommend you look it up.
Yeah, thank you. Thank you very much.
Hi, Fiona from Newcastle University in the UK. Fascinating presentation, thank you so much. So my question's around the growing intake and purchase of meat, plant-based meat and dairy alternatives that would be classed as ultra-processed foods, and just thinking about the increase in the intake of these ultra-processed foods. I imagine they fit into the unhealthy plant-based index that you spoke about. Just thinking about the ARCR, WCF, cancer prevention recommendations and ultra-processed food intake.
Again, I am not actually in a research stage at this point, but I think that would be definitely something that they would be discussing. It definitely is on the highly processed end of foods, so I would expect it would be on the unhealthy end.
Thank
but
you.
I don't know what they're using.
Thank you.
Any other questions? Okay, this is excellent. That means we have lots of time for panel discussion, bringing in multiple different perspectives here. And I would like to take the prerogative of opening by asking both of our speakers and any of you who'd like to contribute how we might need to move from, a more global look at dietary patterns when we were back looking only really with evidence about cancer prevention to now seeing this broader scope where we're looking at prehab, we're looking at during treatment and different types of treatments that might be more sensitive to different factors, to longer-term survival, as we've been hearing throughout the conference for many cancers where we have to look at the cardiovascular impact, and this whole concept of across health and how that affects our research and how that affects our messaging as the public reads such and such diet has this effect, and how they interpret and internalize that. So Dr. Shen, would you like to start with that, and then we'll have Ms. Farley also talk on the plant-based perspective, or more broadly, you may also have input on the plant-based or other dietary patterns.
Yeah, sure. This is certainly something that patients are so interested in, and of course we see patients across the cancer care spectrum, and we have to give different recommendations at different stages of disease based on the current evidence. And so it is hard in terms of messaging to the public because there really is no, I would say, unified message that we have in terms of, like you mentioned, Karen, earlier in your talk, the best diet or versus just what the purpose of the diet is. Is it to lose weight, or is it to be overall healthier, or is it to improve tolerability of treatments or improve the efficacy of those treatments? And so I think at each setting in talking with our patients, understanding if they're expressing a certain interest in a certain type of diet, what their goals are, and how we can best help, and then how we can make recommendations in that setting. But I agree, it's very difficult to have unified messaging. And I think what was really interesting from Ms. Farley's talk as well is the use of indices to at least better characterize our patients' diets, because they're, every person is so different, and they have different levels of physical activity, different composition of their diet, different types of foods, plant-based, plant-forward, et cetera, and all these different definitions. So the concept of using an index is really interesting to kind of better understand a patient's risk based on exactly what they're doing, both in terms of activity and diet, and then hopefully in the future we'll be able to correlate these indices with outcomes so that we can say, look, you fit into this specific category. This is what we predict, your risk would be based on our data, and so this is how I can best advise you. That would be the future goal, someday that we'd get to, but we're not quite there yet.
That's fine.
I find it's interesting to try to advise people to eat a healthy diet, because what's healthy for one person at one point in their journey is not necessarily what might be healthy for them once they're at a cancer-free, just in survivor mode. Treatment and post-treatment may be a different dietary concern, and as is prevention. But I think that the inclusion of unprocessed plant foods as much as possible is what I can recommend across the board. And as people just add that, I often tell my patients, you add more of these things to your diet, you'll just eat less of the others naturally. So make your goal just to eat more of the healthy foods and find dishes that you actually love making, because there's so many different cultures. We're always talking about the diversity, and I think, again, these indices can also apply to using cross-cultural different foods when we're not just specifying this food, this food, this food, and leave a wide variety for so many different foods that people are going to have in their diet.
Was there a question over here?
No, I had a comment, now I've forgotten, and I had something else to say. I was just waiting for the panel discussion. I'm going to put my nutritional epidemiologist hat on. Wear lots of different hats, but that's a hat I'm going to put on. Carrie Daniel McDougall from MD Anderson. What you just said, Karen, about how we're going to expand to different areas and how we're going to understand different scenarios, I just want to tell everyone in the room that you should probably start where every good dietitian starts, by asking the patient what they're eating already. So I really think that something we can all do that is not a heavy lift is start asking cancer patients going on to different therapies what they're eating. Now the challenge is that nobody wants to take more than 10 minutes to do anything, and that's not an in-depth diet assessment that will tell you about whether the plant food they're eating are processed or unprocessed. If you use a short questionnaire, you're not going to get that level of depth. You're not going to see cultural patterns. You're going to fit them in a box. So I would just say, I think one of the themes that I heard is, you know, we're kind of moving from preclinical models to giving patients specific diets. You were talking about all the nuance and, of course, how you address the patient. And I feel like that's kind of an appropriate comment to have between those two things, that we kind of need to start with where the patient is. We can do that on a global scale, or we can do that on a one-on-one. But I think that will be very useful in terms of moving forward to understand what different strategies we can use to help them. And of course, longitudinally. Don't just do it once and walk away. We probably need to understand how it shifts and changes. That's the reason why everyone's so terrified to do things in cancer patients, because they have a lot going on, and they expect that all those things going on will negate whatever we can see with diet. We just have to ask the questions more often, I think.
I think that's an excellent point, and one of the challenges of dietary pattern research, the whole evolution of dietary recommendations based on dietary patterns came as we saw that looking at individual nutrients, how much carbohydrate, how much protein, how much fat, how much vitamin, you know, whatever, wasn't enough to define the overall health effects. So we look at how those foods come together in a dietary pattern, but then we have to remember that a dietary pattern is made up of the food choices you made to get there. And so within these same broad categories, whether it's plant-based or carbohydrate-based or process-based, even when we look at the indices looking at processed food like the NOVA system, we in broad terms talk about, oh yes, eat a less processed food diet. But when you actually look at how things are scored within the NOVA system, which is one of the most commonly used systems in research right now, even that's not quite like we have a label on it, but actually people are often unaware that a refined grain like white rice or plain cornflakes, as long as there's no fat, salt, or sugar added, or ingredients, nutrients, fortification beyond what was originally in that grain, is not a processed food. It is classified at the lowest level of processing as an unprocessed food. And likewise, whole grains that we recommend as being an unprocessed food, according to the NOVA system, if that whole grain bread has an emulsifier added or an isolated fiber to increase either nutritionally or for baking purposes, that is now classified as an ultra-processed food. So, you know, we get these concepts, but then the actual implementation, we're always going back and forth in this cycle between the pattern and the specific choices an individual makes, and if the label that's used in a research study is really getting at what we're trying to get at. Yes?
Hi, Sam Orange from Newcastle University. There's been quite a lot of talks over the past few days about low carbohydrate and ketogenic diets, and I wondered if the panel could comment on whether low carbohydrate or ketogenic diets bring any meaningful benefits, metabolic benefits to patients over and above weight loss or weight gain avoidance. So my understanding of the etiology of insulin resistance and hyperinsulinemia is a positive energy balance leading to the accumulation of free fatty acid intermediates, which comes from positive energy balance. And so my question is then, if energy is matched between diets and protein intake is matched, would a low carbohydrate diet bring additional benefits to weight loss, to a diet that promoted equal weight loss?
Dr. Shen, why don't we let you start with that, and then we can all weigh in.
Sure, that's a great question. So, I mentioned the weight loss benefits, like you said, and benefits on insulin parameters, but really no robust conclusions about cancer-specific outcomes. And so comparing these types of diets with other diets head-to-head, like a plant-based or plant-forward diet, really has not been done in a cancer setting, so it's very difficult to say. But I think the tolerability and the safety issues make keto diets at least a significant concern. When we compare low-carb and keto diets directly, which has been done, low-carb diets seem to be much more tolerable and achieve very nearly similar metabolic effects. So at least improvements in insulin levels and glucose levels, in hemoglobin A1C to a similar degree. And so at least that kind of middle-of-the-road diet is a little bit more tolerable in general, but no head-to-head comparisons against these many other types of diets.
I wonder if I could just very quick comment. We could probably extrapolate interventions that have compared these diets from other populations. So I'm aware of quite big meta-analyses comparing isocaloric diets between low carb and high fat diets where protein intake is matched. And my understanding of that literature is that there's no difference in insulin parameters. So I guess we can probably perhaps extrapolate those big meta-analyses from people with type 2 diabetes or pre-diabetes to cancer survivors or prevention of cancer, given that we think it's insulin resistance, driving that.
Right. And that's why I think it's so important to understand, especially from a patient perspective, if this is something that they're interested in, what the purpose of engaging in that type of diet is again. So if it's weight loss, I don't think these diets are necessarily the best method because in terms of overall health, there's these detrimental effects. And as you pointed out, other dietary patterns can be equally effective in achieving that same weight loss. So I definitely agree. It has to be in these very specific settings.
And I think we can also look to areas of nutrition research outside the cancer-specific realm to address this question of what dietary choices can reduce hyperinsulinemia and particularly postprandial glucose and insulin surges. We know from the diabetes literature that there are many ways, including, not just diet, but physical activity, post-meal consumption. We know that from glycemic index studies that an individual food itself is not the driver, that other foods consumed in the same meal, that the context of a life in terms of even sleep and so forth, all of these things impact the glucose and insulin response, so that a dietary pattern, we start with that objective, as you said, but then we can look at the broad range of steps to achieve that.
Right. Even things like the order in which you eat foods on your plate can impact that insulin spike afterward, So I think this just speaks to what someone earlier said as well, is really understanding what the patient is eating and how they're eating and taking the time to do that. And incremental change towards whatever goal it is that we're trying to achieve is so important.
Thank you very much.
Yeah, thanks. One last question.
Thank you. So my question, I guess it's more of a discussion point. I wondered your thoughts on the utility and transferability of scores such as the Mediterranean dietary pattern in terms of the potential for adapting these to fit the region. So I guess in the UK we might not cook with extra virgin olive oil or use tomato-based sofrito. So can we create more culturally adapted scoring systems that would be easier to translate and implicate and might be more relevant in terms of translating findings in our cohorts?
Yeah, there have been several scoring systems, for example, on the Mediterranean diet that have been adapted. And that's where, it's so easy to just take the title and say, oh, Mediterranean diet, but look at how it's been scored. And so for those non-Mediterranean populations, there have been adaptations. That's where, for example, they might be looking at the ratio of monounsaturated fat to saturated fat instead of in the original scores that look specifically at the use of extra virgin olive oil. but we also have to recognize that that is different, that there are many ways to get more monounsaturated fat. And so questioning, is that the reason for the benefit, or was there something about that original starting point which had certain phytochemicals in the extra virgin olive oil, and it really did matter whether you got that there or from some other source. There have been tools, screening tools identified both so larger, more detailed food frequency questionnaires based, and more brief, like 14 to 16 item questionnaires that have been developed, I know, both in the UK and more recently some developed in the US.
Great, thank you.
All right, well, I think we need to close out this session. I hope that you have found some new information and maybe just some perspective to use as you look at your own research or comment about other research. For healthcare providers who are here, I hope that this reminds you of the importance of listening to your patient and asking them what they mean by a certain diet, or being careful to explain what you mean rather than just using a label and assuming everybody knows what that pattern is, and recognizing that there are many ways to achieve these patterns or mechanisms that we've been looking at throughout the conference. Thank you all for joining us.